So we're starting out here with chapter 9. This is going to be all about the joints between the bones, basically. So the articulations between bones. All right. I think we're ready to go. We are. So just kind of some basic intro material, first of all, about joints and kind of how we classify them. So another word for a joint is an articulation. And it's just any point where two bones actually come together. That doesn't mean the bones have to be separately movable. So we'll talk about the sutures in the skull, which you guys are already familiar with. Those are joints. The bones don't move, right, separately from each other, but they're still considered joints. So the fact that bones move or don't move doesn't really apply to whether they're a joint or not. If there's two bones that are coming together and articulate with each other, we consider that a joint. That being said, most of the time in here, we're going to spend talking about joints where the bones do move in relation to each other. A couple of basic vocab terms that deal with the study of joints. First, there's arthrology. Arthrology is just the science, the study of joint structure, function, and then also dysfunction. Anytime you have two pieces moving kind of separately from each other, there's a lot of potential for dysfunction and pain and injuries. So people who deal with joints deal a lot with injuries and pain. Kinesiology, you guys may have heard of that term before, and that's just looking at the musculoskeletal movement. So it's kind of the science of movement. Musculoskeletal just means looking at obviously the muscular system as well as the skeletal system, how they move. So that's going to involve the joints. So arthrology and kinesiology are two kind of areas where people focus in human health, specifically on joints. When we talk about a joint name, we're only going to focus on a few, but in general, joints are named based on the bones that are involved, the bones basically that come together. So for example, in your forearm, you have the radio-ulnar joint. That means the radius and the ulna. So the radius and the ulna join together near your elbow as well as near your wrist. So that's the radio-ulnar joint. So you should be able to pick out kind of what bones we're talking about the joint being between just based on the joint name. And then we also classify them based on how the bones are joined together. There's 3 different ways they can be joined together. The main categories being fibrous joints, cartilaginous joints, and synovial joints. We are going to spend most of our time talking about synovial joints. Those are the joints you typically think of, your hip, your elbow, your shoulder, your ankle. All of those really highly mobile joints are synovial joints. I'm going to cover these first 2, the fibrous and cartilaginous, fairly quickly today. There's a lot of really confusing terminology in fibrous and cartilaginous joints, mostly because a lot of the terms sound really similar. They often start with SYN, sin something. So you'll hear a lot of terms that sound like they're the same word today. They're not. Just do the best you can to figure out and remember which term applies to which specific kind of joint. So yeah, that's just kind of a heads up. You'll hear things and you'll think, didn't we already say that word? But it's a different word, I promise. It sounds really, really similar. Once we get into synovial joints, it's not nearly as confusing. And you guys are a lot more familiar with synovial joints. Okay, so first the fibrous and the cartilaginous joints. I'll talk about what joins them together and how that's different from synovial joints. Okay. In addition to there being confusing SYN words, SYN, the fibrous and the cartilaginous joints have 2 names. So the fibrous joints are also called synarthroses, or asynarthrosis would be the singular. So 2 names, 2 words that apply to the same thing. This is where Two bones are joined together by collagen fibers specifically. So that's what defines a synarthrosis. Collagen fibers are joining two bones together. There's a few different ways those bones can be joined. So there's actually 3 different categories within the fibrous joint category based on kind of the structure of those collagen fibers. So I'll talk about that in a minute. In fibrous joints and cartilaginous joints, so these first 2 major categories, there is no joint cavity. And you're probably like, what's a joint cavity? So a joint cavity essentially defines a synovial joint. So these first 2, it's just bones being bound together by some kind of either fiber or cartilage. When we get into the synovial joints, there's a little bit of space in between, and that's the joint cavity. But there's no cavity when we're talking about fibrous or cartilaginous joints. Okay, so that's the basic definition of a fibrous joint. The 3 categories we have are sutures, which you guys are already familiar with in the skull, gomphoses, and syndesmoses. I know, really weird words, and we have another sin already, so do the best you can. I don't know that I have a great way of remembering it, but if you guys come up with anything for how to remember these and separate them out, I am all ears. I've never heard anything that's really that useful to me, at least. Okay, so let's go through each of these pretty quickly. They won't take too long to explain. Fibrous joints are fairly straightforward. So the sutures, you guys are already familiar with these. The best example is in the skull. The bones are usually immobile. They might be slightly mobile. Maybe they shift just a little bit, but especially in the skull, we don't really want a whole lot of shifting of our bones. So fairly immobile. And this, the sutures are joined by short collagen fibers. So they're really short. There's not much space in between the bones. So that's what defines a suture. Not much space in between these 2 bones. So short collagen fibers are sutures. We'll see long collagen fibers in the 3rd category that I'll get to here. Okay, sutures, pretty straightforward. This weird word, gomphoses, this is specifically and only dealing with your teeth. So gomphosis is the joint where your tooth actually connects to the socket within the mandible or the maxilla. These collagen fibers are a little bit longer.
If you have the money, yeah, just like on game.
And that little bit of length, so you can see here, the bone attaching to the tooth. For you guys on Zoom. The bone attaching to the tooth here. It allows for a little bit of movement. So more movement than you have in a suture. Because when you chew, that's a lot of pressure on the tooth and then the bone. So you want a little bit of give, so you don't have a lot of stress on either the tooth or the bone. So a little bit of movement under the stress of chewing occurs in gomphoses.
Is it even acadol or?
And then we have the syndesmoses.
Oh wow.
These are joints that are bound together by long collagen fibers. So the sutures were short collagen fibers. Syndesmoses are long collagen fibers. The best examples here are between those bones in your forearm and your lower leg. So you have 2 bones in each of those right next to each other. And there's long collagen fibers that actually attach. So here on Zoom, you guys can see the long collagen fibers between the tibia and the fibula. That joint, it's considered a joint, as weird as that is, between the 2 bones, can either be highly mobile or not really mobile at all. So in the forearm, that's actually a highly mobile joint. Your radius and your ulna will cross over each other if your palm is facing downward. If your palm is facing up, they're parallel to each other. So there's a lot of mobility there between those 2 bones from that perspective. Your tibia and your fibula don't do that. They don't cross over each other. So they're a lot less mobile.
Because you're not you're not really getting an actual gain.
That's syndesmosis. That wraps up the fibrous joints. So that's our first main category of the joints, the classification. So our next category is going to be the cartilaginous joints. The other term for these is amphiarthrosis. Synarthrosis were the fibrous joints. These are amphiarthroses. Again, no cavity. So bones are joined together directly without a cavity or space in between. But now they're joined by cartilage. So not collagen fibers, cartilage. So different tissue. We only have two types here. We have synchondroses and symphyses. You guys are already familiar with one symphysis, which I'll talk about. And when you see the easiest way for me to separate out at least the synchondroses from like the synarthroses that we talked about, whenever you see that CHOND, that chond, that refers to cartilage. So like a chondrocyte is a cartilage cell. So if you see CHOND, you know you're dealing with some kind of cartilage. So we're in a cartilaginous joint category, if that's helpful to you. All right, so let's talk about each of these, synchondroses and symphyses. A synchondrosis is where bones are joined directly by hyaline cartilage. And if you remember, the hyaline cartilage is the one that's kind of like an amorphous. It has an amorphous matrix, not a whole lot of fibers in it. These are usually, it's most common in temporary joints like the epiphyseal plate. At the end of a long bone, that's what allows for the growth and length of the bone. So we consider that a joint. The cartilage there is eventually replaced by bone once your bones stop growing in length. A more permanent example is the ribs attaching to the sternum. So that's a synchondrosis. That cartilage does not turn into bone. It stays as cartilage your entire life. Okay. And then the symphysis or symphyses. This is where two bones are joined by fibrocartilage. Rather than hyaline cartilage, now we have fibrocartilage. It's a lot more fibrous, a little bit tougher. The example I gave before, and that I think I asked you to know for the exam, is a pubic symphysis, where the two hip bones come together anteriorly. There's a symphysis right here, and it's made of fibrocartilage. So that's considered a joint right there. And in addition to that, another good example are the vertebrae. So the actual vertebral bones coming together. The discs in between there have a lot of fibrocartilage in them. So that would also be a symphysis, or a bunch of symphyses if you include the whole spine. So not a whole lot of movement with symphyses typically. If you add up the entire spine, obviously we have a lot of mobility, but between individual vertebrae, not a ton of mobility. And definitely not a whole lot between the two hip bones. Okay, and that wraps up those first two categories, the two classifications of joints before we get to the synovial joints, I think, right? We got through all of them. Yeah, okay. So like I said, we're spending the vast majority of time in here talking about synovial joints. That's the kind of joint you think of typically. The sutures and the symphyses, all of those you don't really think of as joints. They technically are articulations between bones. So you want to know them and their classifications and some of the examples that I gave you. But the rest of this chapter, is essentially dealing with synovial joints. These are the most common kind of joints. Another word, of course, for them is diarthrosis. And now we have the introduction of a joint cavity. So between two bones, you have a little bit of space, which is called the joint cavity. So you don't have the fibers directly connecting the bones. So there's the joint cavity that we haven't seen yet in the other two main classifications. And that joint cavity is fluid filled. And I'll talk about synovial fluid. But a fluid filled cavity separating two bones, that's a synovial joint. Most common type, they're really highly mobile and therefore very complex. So the more mobile a joint is, the more complex it is. And the more complex it is, the more likely something is to go wrong with it. So if you're interested in anything dealing with like athletics or movement like PT, occupational therapy, anything like that, you'll be dealing with joints a lot. And you'll be very familiar with the different joints, how they work, their anatomies, all that kind of stuff. But those are the main kind of areas in healthcare that will deal specifically with joints. I don't know why I have nurses on here. I mean, nurses do a lot of stuff. I should take that off of there. But athletic coaches, fitness trainers, OTs, PTs, they deal with a lot of issues with movement and thus issues with joints. Okay, so that's synovial joints. I'm going to get into the anatomy of them first, and then we'll talk about the anatomy of synovial joints, the different kinds of movement, so terms for different types of movement, flexion, extension, that kind of stuff. And then I'll actually go into detail on some of the main synovial joints in our body. So I'll cover the shoulder, the elbow, the hip, the knee, and the ankle. So we'll go into detail on those synovial joints after we get through some of this kind of introductory material. Okay. General anatomy. So like I said, these are kind of complex joints. It's not just fibers joining two bones. There's a lot more going on in synovial joints. We've already talked about articular cartilage. This is just the cartilage that's on the ends of the bones. So if you have two bones coming together, you have cartilage, like a thin layer of hyaline cartilage on either end of those bones. That's the articular cartilage. The cavity I've already mentioned, the joint or articular cavity, that just separates the bones. So it's just a little bit of space in between the bones filled by fluid, the synovial fluid. Synovial fluid helps to lubricate the joint cavity, so it allows for fairly friction-free motion. Friction is going to cause issues. It can cause bone spurs. It can cause a lot of pain. So the less friction between bones, the better. So that's where synovial fluid comes in. And then around all of that, so around the cavity, which contains the fluid, you have what's called the joint capsule. So there's this other kind of layer outside of the joint cavity, the joint capsule, that kind of holds all of that together. So think of the capsule as the outermost piece of this synovial joint. So you have the capsule, inside of which is the cavity, inside of which is the synovial fluid. In some synovial joints, not all, you have these pieces called articular discs. And this is just where fibrocartilage is basically growing in from the outside of the capsule. So the menisci in the knee, your knee meniscuses are a good example of these articular discs. Also the discs between your vertebrae. They typically cross the entire joint capsule, and they have a few different functions. I'll talk more about the menisci in the knee when we get to the knee specifically later. I guess probably Wednesday we might get to it. But you have these, they're kind of moon-shaped or C-shaped menisci in the knee. So those are just articular discs. They are going to help with a couple of different aspects of joint movement. So they're going to help absorb shock and pressure. So they're kind of like little pillows within your knee. And then they also help improve how the bones fit together. So they'll help the femur and the tibia here fit together a little bit more securely than if they were not there in the first place. So those are the two main functions of articular discs in general. In the knee, they have a couple of extra functions that we'll talk about when we get to the knee, but in general, these articular discs kind of help bones fit together a little bit better and help absorb shock. Again, those are not in every synovial joint, just some. In pretty much every joint, you're going to have one or more of these accessory structures. So there's tendons, there's ligaments, and there's bursa. You guys have probably heard of tendons and ligaments. They're often used kind of interchangeably in everyday speak, but tendons technically attach muscle to bone, ligaments attach bone to bone. So the only difference is basically what they attach. They're both made of collagen fibers, so same tissue type, but muscle to bone for the tendon and then bone to bone for a ligament. The bursa, which you may not have heard of, are just fluid-filled sacs that are found in or near a lot of these tendons and ligaments, kind of around the synovial joints. So they can be between muscles, where you have tendons kind of passing over bone, or between bone and skin. And it really just helps, kind of like the synovial fluid, to decrease friction between those elements in the musculoskeletal system. So you may have heard the term bursitis before. I feel like that's something that typically older people get, but younger people, if they're really active, it can happen as well sometimes. But the bursa, these fluid-filled sacs, just become inflamed and it causes pain. So they're not really as effective if they're inflamed. They're not helping kind of smooth that passage of the tendon over the bone or the skin over the bone. So it can be pretty painful. So that's where the term comes from, bursa, bursitis. Basically an aggravated bursa is bursitis. Okay, so those are the three accessory structures that I want you to be familiar with in a synovial joint. And then I want to take a minute here to talk about exercise and synovial joints. So when you don't use your muscles, obviously they deteriorate. If you don't use your joints, they do the same thing. So if you don't move all that much or exercise, your joints actually start to deteriorate. Specifically, the articular cartilage on either side of that joint, so the ends of the bone, will deteriorate, and it can cause a lot of pain and make it harder to move, which makes you want to move less. So it's kind of this vicious cycle that if you don't actually move a whole lot, it can cause issues and a lot of pain in these synovial joints. So I'll just describe kind of what happens during exercise in these synovial joints. So as you're exercising or warming up, the synovial fluid in that joint is going to warm up as well. It'll become less viscous and kind of a little bit more fluid. And when it becomes less viscous, it is easily absorbed by the cartilage, by the articular cartilage. So here you can imagine the synovial fluid becoming more liquidy, and then it gets absorbed into that articular cartilage. That really thin layer of cartilage on either side of the bone, which is a good thing. So it gets absorbed into there. The cartilage is then going to swell up with that extra fluid in it. That helps provide a more effective cushion between the bones. So you want that cartilage to swell a little bit with synovial fluid before you really do any high impact exercise. If you just go right into high impact exercise, you don't have that initial kind of extra padding of the swelled up cartilage. 1 or 2 times, not a big deal, but if you kind of constantly go into intense high impact exercise without warming up, over time it can cause some issues in that joint. So warming up is important for exercise to start with. It warms up that synovial fluid. So now we'll imagine you've warmed up the synovial fluid. There's a lot of synovial fluid in that cartilage. It's acting as a nice pad between your bones, which is always good. And then as you say you're running or something, that cartilage is basically being compressed over and over again. So if you imagine in your knee when you're running, the cartilage is being compressed over and over again and actually squeezing out some of that synovial fluid. It's almost like a sponge. So it's taking it up and then squeezing it out. And as doesn't really sound like a great thing, but that is allowing it to release metabolic waste. So this cartilage on either side of the joint on the edges of the bones is metabolically active. It has wastes in there. If you don't squeeze out those wastes, then the waste tends to build up a lot faster and can lead to deterioration of the cartilage. So you want that articular cartilage to soak up the synovial fluid and then basically squeeze it out with exercise over and over again. That synovial fluid is also going to bring with it nutrients and oxygen into the articular cartilage. So it'll be replacing that waste with healthy new nutrients and oxygen, which is great for the cartilage. So it keeps it a lot healthier, makes it last a lot longer. And the more you exercise, the more this happens, right? So if you don't exercise, like I said, if you just end up sitting all day, not really moving a whole lot, that metabolic waste builds up in the articular cartilage and never really gets squeezed out, and that cartilage never gets any, or doesn't get a lot of nutrients and oxygen like it would if you were exercising. So you guys are still young, you probably move plenty, but as you get older, just remember that, and maybe your parents, they probably don't move as much as you do. Just remind them that if you keep moving, it keeps the joints a lot healthier. Once you stop moving, the deterioration, especially as you get older, can really progress and accelerate. So movement is key, even if it's just walking. That's going to help just lubricate the joints and keep that cartilage in good shape. Okay. There are 6 different classes of synovial joints. So the other types of joints we talked about, the fibrous and cartilaginous, there are only 2 to 3 types. Now we have 6. So it's getting more complicated. Most of these involve some kind of depression in one bone, meeting up with kind of an extension in another bone in one form or another. But I'll go through each of these, give you some examples of each of them. So we have the ball and socket joint. Most of you are probably pretty familiar with those. The condylar or ellipsoid joint, saddle joint, plane or gliding joint, hinge and pivot. So we'll walk through each of these classes. Okay, first we got the ball and socket joints. This is where a hemispherical head fits into basically a socket or a cup-like depression on the other bone. So your hip is a great example, your shoulder, your femur fits into your hip socket, right? So that's a ball and socket. Your humerus fits into a depression in your scapula. These are really highly mobile. So ball and socket is going to be the most mobile of the synovial joints. There's a lot of range of motion in a ball and socket. The condylar or ellipsoid joints, sort of like a mini ball and socket, I guess. They're a lot smaller, but you do have sort of a hemispherical piece fitting into a cup-like depression on the other bone, but not quite a ball and socket. So the ball and socket would have a little bit less overhang here, essentially, and allow for a larger range of motion. A good example of these are the knuckles. So where your metacarpals meet up with your phalanges, hence the metacarpophalangeal joint. It's a really long name, but you can tell that it's the metacarpal plus the phalanges. So where those two meet, that's going to be a condylar joint. Okay. Saddle joints are next. They sound like what they are. They're basically two saddles that fit together. So one saddle is going to be convex and one saddle is going to be concave. So the concave and the convex pieces meet together to fit together for the joint. Another example of this in the hand is the joint between the trapezium, which is the bone right below the thumb in the carpal region, and the metacarpal of your thumb, essentially. So that's going to be a saddle joint. You can't really tell that it's a saddle joint just from the diagram. These are a little bit harder to see. Oh, and then the sternoclavicular joint. So where your sternum meets up with your clavicle, that's also going to be a saddle joint. The plane joints are unique in that we don't really have depressions, like with a cup-like socket on the other side. These are where two essentially flat pieces of bones are meeting together and kind of gliding over each other. So there's no depression, no extension, just two essentially flat bones sliding over each other. That's why it's called the gliding. A gliding joint is another term for it. Not a whole lot of movement between these. So the examples I give here are between the carpal bones, between the tarsal bones, so all those little bones in the wrist and the ankle. And then also between the vertebrae. So if you look at one vertebrae up against the next, that's going to be a gliding joint. You have two flat bones basically passing over each other, just a little bit of movement. And the last two we have are the hinge and the pivot joints. These are actually pretty easy to grasp. A hinge joint would be like your elbow. It's movement in basically one plane. You still have a convex surface fitting into a concave depression. But with a good bit of movement, obviously. So your knee, your elbow, those are hinge joints. And then between the phalanges of your fingers and toes, so those are going to be hinges. You can really only move them in one plane. And a pivot joint is going to allow for a very different type of motion from the others that we've talked about. It's actually going to allow for longitudinal rotation on an axis. So your head rotating on the spine basically is a good example of a pivot joint. So that's where your atlas and your axis come together, the atlantoaxial joint between C1 and C2. So the bone will just rotate around kind of the central axis or fulcrum, if you want to think of it that way. The radio-ulnar joint is another example. So at your elbow, you have kind of multiple joints. You have the humerus joining the radius and the ulna, and then you have the radius and the ulna joining each other, right? So you have a joint there. So your radio-ulnar joint, your radius actually rotates around the ulna when you turn your hand either facing up or facing down. So that's a pivot joint. And those are the 6 classes of synovial joints. For the most part, when I get into the specific synovial joints we'll be talking about, it'll be ball and socket, and mostly ball and socket and hinge. That's what we'll be focusing on. Okay, so now we're going to get a little bit into some vocabulary dealing with movement. So since we're talking about joints, joints allow us to move. We're going to talk about some of the terminology dealing with movement of the body. First, anatomical position in reference to these movements that I'm going to talk about is called zero position. So zero position is what we're going to start with. And the terms that I'll go over are basically going to talk about deviations away from that zero position or back to it. So when you move, when you flex your arm, you're moving away from zero position. When you extend your arm, you're moving back towards zero position to be back in anatomical position. So keep that in mind as I go through these different terms. The first 2 are pretty easy to understand, flexion and extension. Flexion is going to decrease the joint angle. So decrease the joint angle compared to zero position, right? So if you're standing like this and you flex your arm, that's going to decrease the angle. I don't know if you guys on Zoom can see that. It's going to decrease the angle here. This would increase the angle. So need a little bit of geometry here if you guys remember angles at all. So this would be like a 180-degree angle, a 90-degree angle. So you're decreasing the angle. That's going to be flexion. It's pretty straightforward. You know, you flex your arm, you bend your elbow up, right? But there's knee flexion and hip flexion as well. I'll show you those on the next slide. So decreasing the angle is the definition of flexion. Extension would be the opposite, increasing the angle. And it's basically returning to zero position. So extension would be back to zero position. There's also hyperextension, which in your elbow, not a good thing. Your knee, not a good thing. But other parts of the body can hyperextend, and it's not a problem. So your wrist is a good example, like on this slide. So extension would be zero position. If you flex your hand or your wrist, you're decreasing the angle here. So that's going to be flexion, extension back to zero position. And then hyperextension is just where you pull your hand up essentially. So hyperextension in the wrist is not a bad thing up to a certain point. So now the angle is really big here, right? It's greater than 180 degrees. So that's hyperextension. You don't want to do that to anything that doesn't want to hyperextend, but hyperextension is not always a bad thing. Okay, and then if we look at the hip and the knee, so you'll often hear something about hip flexion, well, often, depending on what you do, hip flexion, knee flexion. In order to flex your hip, you want to decrease the angle between the torso and the thigh. So hip flexion would be bringing your thigh up, and now that angle is no longer 180 degrees like it is when you're standing with your leg down. So that's flexion. Extension would be putting your leg back down. You can hyperextend it and pull your leg back, right? So now the angle is actually bigger. So you can hyperextend your hip. And then knee flexion is just bending the knee. So now the angle here is smaller than the angle here. So you have a small angle versus the typical 180 degree extended version. So knee flexion and hip flexion. So it's not necessarily about which direction you're moving your body in. It's more about the angle when we're talking about flexion and extension. And good old abduction and adduction. So abduction and adduction. It's really hard to, if I use those terms, I'll try to say that. I think adduction versus abduction is a little bit easier to understand. Otherwise, you can't really tell, especially with the mask on, what the heck I'm saying. Okay, so this is just where you're moving parts of your body either away from the midline in the frontal plane or towards the midline. So abduction, the example here is her moving her arms out away from the body, away from the midline. So we're talking about in reference to the midline of the body. That's abduction. Moving your arms back down towards the midline of the body is adduction, adduction. This is kind of a dark way maybe to remember this, but these are easy to confuse, right? They sound almost exactly the same. So abduction, abduction, if you get abducted, you're taken away. So your arms are moving, or whatever you're talking about, is moving away from the midline. So abduction is moving away, like you're being taken away. I guess it's not that dark, a little bit. Okay, abduction and adduction, elevation and depression, super easy, straightforward. You either bring a part of your body up or you move a part of your body downward. So we're talking in the vertical plane, so up or down, elevation, depression. And then protraction and retraction. Pro means forward. So protraction is where you're moving a part of the body forward. So here in that diagram, we're looking specifically at the shoulder. So if you push a door open, you can think of it that way, you're moving your shoulder forward in the horizontal plane. So either forward or back is what we're talking about here with protraction and retraction. So protraction, you're moving your shoulder forward. Retraction, you're moving your shoulder back, or whatever body part you're talking about. But we're talking in the horizontal plane here. So kind of back and forth this way, not any other direction, just anterior or posterior. Circumduction is pretty easy to understand. It's where you move one end of an appendage in a circle and the other one stays, hopefully, in the same spot. So your shoulder is going to stay in the same spot as you move your arm around. Basically, I mean, for the most part, this is just in reference to your arms and your legs. And then we have rotation, which is where now we're talking about a bone moving or rotating on its longitudinal axis. So the example here is either rotating inward, so your arm rotating inward or outward. So your humerus here is what's kind of rotating, right? So your humerus is rotating either medially, internally, towards the midline of the body, or laterally, towards the lateral or outside of the body. So the bone here, the humerus, is spinning longitudinally, or yeah, her leg too. So the femur can do it as well. So you kind of have to think in this case about what bone is actually rotating. So you have medial and lateral rotation. And this often comes up with Injuries, if you, obviously if you rotate your legs, different parts of your legs in different directions, that can cause some major issues with your knee, lots of tearing, all that kind of stuff. So rotation is a really important aspect when you're trying to figure out kind of how something was torn, or things rotating in different directions that they shouldn't have been, etc. All right, we'll stop there for today. We'll talk about supination and pronation, and I think a couple other terms on Wednesday.